sounds like you would want to see a similar type prohibition to private equity buying physicians' practices in rural America, just like Trump is stepping in on the housing issue.
I do. It's a really big problem. Large health systems and private equity, we need to stop this. But then, I will just say that this is ultimately, I don't want to say the fault, but, this is the manifestation of Obamacare. Of 20 years out or whatever it is, that a lot of these independent providers are struggling because they can't do the electronic medical records. They can't do, some of the huge regulatory things that the government's putting on them. And so they're struggling to survive. And then the big shark comes and eats them. And then in the end, the real people who suffer are these patients.
This is DCEKG. Exploring the intersection of politics and healthcare by diagnosing Washington and prescribing solutions. We take a deep dive into the legislation, regulation, and innovation impacting policymakers, providers, and patients. Now, America's health policy expert, Joe Grogan.
Welcome back to DCEKG, where we discuss the policy elements in Washington, D.C. and prescribe needed solutions. And today we're joined by Dr. Manny Sethi from Vanderbilt and Healthy Tennessee. So, Dr. Manny, thanks so much for joining DCEKG.
Thank you so much for having me, brother. Really appreciate it.
So let's start for a second. Just tell us a little bit about your background, where you're from, and how you ended up in medicine.
Sure. My story is, the basic sort of immigrant family story. My parents were from India. They came to this country with basically nothing, and were both doctors in small town Tennessee, in a small place called Hillsborough, Tennessee. My mama is an OBGYN. My dad, who passed away, was a primary care doctor, and they were the only doctors in this little town we were in, taking care of the whole community. And that was my first sort of introduction to being a doctor, and just watched my parents both be pivotal parts of the community, helping people, making a difference in people's lives. Then I, developed a very deep interest. I remember my dad one time in a grocery store did CPR and saved somebody's life, and I was like 12, and it just,
oh my gosh,
I was like, this is something that I really want to do. And my faith is a very kind of important part of my life, and the book of Matthew teaches you to kind of help people make a difference. So I went to medical school and became a trauma surgeon, and now I'm a orthopedic traumatologist at Vanderbilt. Been there about 15 years. Been a long run.
Just so for people who aren't aware, an orthopedic traumatologist, that's broken legs, broken arms.
Yeah, it's just a fancy word for, you get, hit by a car, or you're in a car accident, or you fall off a roof, or
big ones, big problems.
Yeah, break your pelvis, break your femur. We do a lot of that. So, when you think about orthopedic surgery, you think about total hip replacement, total knee replacement. I don't really do much of that, but I deal with a lot of high energy trauma, like high car accidents, gunshots, that kind of thing.
So the first time you see a patient is in the emergency room?
Yeah, pretty much. Yeah, most of the time.
Okay. So and then do you have an outside practice as well where you see patients?
Yeah, we typically, most of our intake comes from the emergency room, as you mentioned. People who get, initially injured, you've got 20 minutes to get to know them before you take them to the OR. And then, you see a lot of those folks in follow-up. So I have a clinic where I see some of those patients. And sometimes we do something called cold trauma, where we take care of patients who have problems that maybe weren't managed the right way, or just didn't do well. So so there's a host of things that we do.
All right. So, but you're also interested in let's say, solutions beyond just the individual patient, as laudable and noble as that is. Probably maybe the most noble profession you can have, frankly, is trying to heal people. How did you come about founding? Did you found Healthy Tennessee?
Yeah, my wife Maya and I we founded Healthy Tennessee together back in 2011. The reason I got interested in this is, when I first started medical school and through my training, I trained in Boston. I'd see all these patients, with like bad diabetes renal failure and lots of heart disease. And, we're treating all the secondary problems of this, right? We're taking them and they're getting a cardiac cath, or they're getting diabetes, and then they're getting renal failure because their kidneys are shot because of their high blood sugar and all that stuff. And so we're treating all these problems downstream, but we're not kind of getting on the front end of the problems. And that really trickles into what I do as a traumatologist, or as an orthopedic trauma guy, because a lot of these things affect what I do and the outcomes. Like a healthy person who breaks their femur is very different than a person with diabetes or heart disease who break their femur. And I was always just curious, like, why does the Medicaid program, why are we paying for all this stuff on the back end when we could treat people on the front end? And so, I'd spent some time with policymakers talking to them about it. They didn't really seem to understand it, nor did they really care. I got so frustrated after talking to all these people that I was like, look, we need to do something on our own. And we came up with the idea of Healthy Tennessee that took care of multiple problems at one time. The issue that in rural parts of America, there's just not a lot of access to care. But secondarily, you can minimize the need for that access through educating folks about prevention and preventative health, and learning to get onto the front end of problems. And so, we had one health fair. The first one was in Manchester, Tennessee, where I grew up. My third grade summer camp counselor showed up, which was very cool.
Awesome.
And yeah, we screened 100 people. It was before I even had kids. And we had 8 or 10 kind of volunteers and vendors. And then, the next one we did was a month later. And then we had some more volunteers. And, then we did another one. And then more people showed up. And then.
So when you say, wait, so the volunteers are other physicians and nurses, or people, that's who volunteers?
Lots of physicians, lots of nurses. Nurses are incredible, man. Nurses, right. I'm just amazed. We had one this past weekend, and nurses, they just show up. They just want to make a difference. So we had doctors too. I mean, not to beat on doctors, but but then you have other folks that you wouldn't think about that are really helpful. Like the fire department. For example, the fire department showed up at one last weekend, and they were teaching infant CPR. And just imagine somebody comes through and they're learning that infant CPR, they could save someone's life. And healthcare people would screen their health. We check their blood glucose in the beginning, simple things, and their BMI. And then, as we became more sophisticated and got partnered with United Healthcare, we partnered with the Blue Cross, we were able to do more. We were able to do urinalysis. We were able to do lots of various mammograms. We were able to do, lots of screening things. We had a dentist, we had ophtho, a lot of different things. And I can tell you different stories of crazy things we picked up along the way. But the bottom line is it is a community-based approach with an all-volunteer army that focused on prevention. And over time, we just grew to the point where at these events, we had about 1,000 people show up for screening. And it's just crazy, man.
So why, let me ask you this question. I got to ask a threshold question. So Healthy Tennessee is a not-for-profit organization. You have a budget, you collect donations from the community, from companies, from who gives you money?
So, we put the seed money in back in 2011, and then, private donors gave money. We had someone who became very, very interested in what we were doing, and they wrote us a very large check and made a huge commitment to us. United Healthcare partnered and has sponsored us. Blue Cross Blue Shield, other major corporations have donated. Community leaders have donated, but business leaders. So it's just a lot of different kind of touch points of folks.
Okay, so what's in it why would Blue Cross or United do it? Is there a commercial advantage? Is it a funnel for them to get patients, or is this a gap that they're this is healthcare adjacent and fits into our philanthropic bucket?
Yeah, I would say both of those reasons. So, for example, Blue Cross came on board with us with a very interesting initiative that we did. So, as a nonprofit, let's say on a Saturday, we have a health fair, right? We did one of these, I think it was in Gatlinburg after there were some fires there back in I don't know, 2018, 2019. And right like a mile down the road from us was some other like group doing a health fair or doing something. And I was like, man, like we could have pooled resources. And so I got this idea that we should work with every community health organization in the state to partner and know what each other's doing, to basically stop working in silos and work together. Blue Cross was very, very interested in that. So that was kind of the policy, one of the policy arms of our efforts. So Blue Cross, they donated a lot of money for us to build a community-based listserv of all these organizations and bring them together. There are 3 grand divisions of our state: East, West, Middle. We had like these meetings in the East. The Surgeon General of the United States came. We had like a meeting in the West. We brought all these nonprofits together. A meeting in the middle, brought all of the Middle Tennessee. And then we had a huge meeting of all 3 together where we brought nonprofits together to create a mission statement of like, what can we do together? So Blue Cross, not only do they donate to our health fairs and stuff, but they really donated to that. And they also donated to something that we did called the Healthy Tennessee Challenge, where we work with children on sort of education of opioid abuse, because that's something else we're very involved with. And we created this program for kids to basically educate other kids about why, marijuana, fentanyl, all these things are really bad. It was like a high school to high school, basically like competition across the state. Man, it was amazing. Like all of these schools got involved. It was just awesome. And Blue Cross supported that, and we gave the winner like a couple $1,000s, the winning team, to donate to their charity. So Blue Cross got involved with that. Now, United, they partnered with us because we go into rural parts of the state where there's places where we go where there's barely any cell phone service, or, United was like, hey, if you're going to these places, we would love you to screen our, Medicare D population.
So who comes to these events when you set up, and does it vary depend on the geographic location? If it, talk about like the variety of geographic location and also the variety of patient who shows up.
It's really evolved over time with the patients that we see. So, early on, it was mostly uninsured folks who needed something, right? They needed, hey, I have this problem in my leg. Like they came for a reason, like they needed something. And I think over time, now we're just seeing all comers. Like some people have insurance and they just are like, I can't get in to see a doctor, or uninsured folks. And I think the reason it's changed a little bit also is now we partner with food banks. So we partner with Feed America First and with Second Harvest. And so people can come to our health fairs. They get free food for their families, and provided that they go through the screening. So that's also changed a little bit. But I would say the evolution of it is we used to see like totally uninsured folks, but now I think it's a mixture. I'd say it's 70-30, 70 uninsured, 30 insured, where it used to be like 100% uninsured folks. Like, for example, I'll give you an example. This weekend, we saw a lady, very nice. She came in her 30s, and she had a breast mass. And she's like, I have no insurance. I can't get in. Do you think this is a problem? Look, and I looked and I was like, yeah, this is a problem. And we had somebody there. And so we connected her with the Rutherford County, that's Murfreesboro, Tennessee, health department. And they're going to basically get her in and get her to the right place, get her a mammogram. So you see things like that. You see things like, hey, I haven't had my blood pressure checked in 20 years. And I, can you help me? Hey, I just want to talk to a doctor. So you see a lot of different stuff, but the fascinating thing to me is I think we see more patients now with basic health insurance because they just they can't get access to a physician.
Okay. So that's a really interesting point. I just want to press on this for a second. So
yeah,
somebody with insurance shows up to see you, and that's their complaint. They can't see a family physician or an internist, or they can't see a specialist, or what?
I think both. I think sometimes they can't see their like a basic primary care person, or they're not around, or they're just busy, or secondarily, they have some problem and they don't have access to a specialist.
Okay, so I have this warped vision of what this might be in a rural area. When you mention an event with 1,000 people, I see a long line of people.
Yeah.
You're standing, you're there for a while, kind of a hassle. But it sounds like, I mean, if somebody's got insurance and they're going to see you, maybe it's not such a hassle. Like, what is it? How do you organize these things so that people are not quitting after 10 minutes or 15 minutes and saying, screw this, I'm going to go home. I haven't had my blood pressure for 20 years. I don't need it for another 20 years. This is too much of a pain in the neck.
Because we got it down to a science, brother. We got so many volunteers in the ground. We have a meeting before. We have a sequence. Yeah, we have a team that literally they have just done this for 15 years. Like they just set these up, and it's like surgery. The first time you do a procedure of some kind, it's hard. But when you do it 100 times, it's much easier because you know the ins and outs of like the problems, where the problems are, what the problems are. Hey, I've done this before. And setting up these fairs is very similar. Like the parking is here, that people are gonna have to come through here. We're gonna register them here. Like, so we just have a sense of how to do it now. And so the lines are minimum. Now, I will, did we get it right? Like, we were in Chattanooga, Tennessee many, many years ago. We were supposed to be there from 9 to noon. We were there till like 7 o'clock at night because we just weren't good at it. Like we had a ton of people. We had a ton of lab capability. It just took a long time. So we learned from those things, how to do it. So the average wait time for one of our patients is about 15 minutes when they come.
That's right.
So, yeah. So this is great. It's great. And
shorter than a normal doctor's visit.
Oh yeah,
right?
Yeah. Normal doctor, no judgment. We give you this it's called a passport. We give you a little passport, with your data on it. You go from one place to the other place, and everybody fills out your passport. And then you talk to one of the physicians, either me or another, somebody else. I typically like to try to talk to most people if I can, because it brings me a lot of joy. I can just get to the bottom of like why people want to be there or what we can do to help them. So
you just put tremors in the hearts of some people who listen to this show who are big health IT, electronic health records people. Is this a paper passport that they're walking around with, or do you have iPads that you enter it into? Because there is a view of many that unless it's an electronic record, it's might as well be akin to leeches.
Well, so a couple things. It depends. If it was a United patient and they have, it all goes into like an iPad or a, electronic health record mostly, but they enter it on the iPad. My sense of the health IT thing is, I think patients, and that's just a whole nother discussion, but I think patients want human touch. I think when they see something written down with a pencil or a pen, your blood pressure, your BMI, I think it's powerful, but that's me.
Yeah. No, I mean, listen, one of my great frustrations, EHR is one of the great frustrations in public health, I think, in the last 20-some years. And it drives me nuts to be in the emergency room and the iPad is getting treated and not the patient. There's no eye contact with the patient. There's no conversation with the patient, really. It's about just give me these vitals so I can enter them. And it takes so long, and it's awful. It's awful. Anyway, we'll see. I mean, there are some advances now with some of these conversation apps that are populating the record. But we could go down a whole rabbit hole there. But feel free to, bash electronic health records or anything you want to bash on this. So.
Well, can I just add one thing? Because this fits into the Healthy Tennessee model. I think with all these things like this DAX Copilot and all these like auto population things, and I think it's really important to know people's stories, who they are, where they're from. Even if I have 20 seconds with a patient at Healthy Tennessee, I think that's what we do really well, because I think to build trust with patients and for you to really help them, they got to trust you. And that comes from communication and interaction and knowing who they are. And that's why I think this whole AI thing is just, I think it's going to lead to a large degree of unsatisfaction, but that will remain to be seen.
Right. Okay. Well, we'll stay tuned. All right. So I want to get to talk about rural health and the unique factors in, or maybe not unique, but the factors in rural health and some of the policy flaws and what needs to be done to deliver good care. But as a threshold question, you said you trained in Boston. Were you ever tempted to stay up there in the big city, or were you like, screw it, I'm going back to Tennessee. I saw my parents practice in a small town. I want to go back to my home state.
Well, I was in Boston, man, more for my father. It was his dream that his son go to Harvard Medical School and train at Harvard. And so I did that. It was really important to my family, so I said, okay, I'll go do it. And I knew that I wanted to make a bigger difference, and I knew I wanted to come home because Tennessee sort of made my family's dreams come true. Basically, the American dream in Tennessee is what I would call it. And so I knew that I wanted to come home the day I graduated.
Right. And no looking back, I would think, after all this. I mean, Tennessee has done, it's just been an amazing place for healthcare over the last couple decades, right?
Oh, yeah, it's incredible. And, the thing that about Tennessee that I think is very surprising is that, you have the center of healthcare tech, which is Nashville, which is 60 miles down the road, man. You got people who are suffering because there's just not a primary care doctor around, or there's not a good hospital around. And that to me is just insane.
Yeah. Okay. Well, let's talk about this. So rural healthcare, what are the biggest problems in delivering healthcare to rural America from your perspective? Is it access? Is it coverage? Is it not enough physicians, not enough nurses? Is it reimbursement? How would you define the problems in getting these people care?
Well, I would say honestly, it's all of the above. It's all of the things that you just mentioned, and I think I think the biggest issue is access, is actually finding someone, and I think that look, I will just put this out there first. I'm a big fan of let's just get the job done, right? So there's all these turf war, should nurse practitioners be able to independently practice in these rural places? Should I just think we need to get folks access. Like that's number one, right? And the problem right now, and I'm sure you're probably aware of this, but your listeners may not be. One big challenge is that the few primary care physicians or offices, and the specialists in these small towns right now are being eaten up and bought up by private equity, right? So what's happening is that PE is buying up all of these places, and then they are negotiating with insurance companies. It's making it harder for patients to get in. So we only had a few providers, but now it's being monopolized by private equity. And so it's making it harder for patients to access care. And I know that the counter argument that these people are making is, oh, we're making it easier, and they're not. And I think we have to figure out a way to incentivize more providers to go to rural places. And I think, like the Medicare index, that's fine. But I they argue that they do compensate and do things, but I think we could do a much better job.
So not enough physicians, not enough nurses in rural locations. And then can we talk about this dynamic a little bit? So you have a small doctor's practice. I don't know, 3 doctors, 4 doctors. Does private equity buy a firm that size?
They're buying everything. And then they're negotiating with the insurance companies,
And how does that play out? Like, why does that lead to less access?
Well, okay, great question. Let's say that, you are on the healthcare exchange, or you're on your own cooperative health insurance plan, or whatever it is. But now these PE guys come in and they say, well, we're only work with Blue Cross because Blue Cross is like giving us this monster deal, right? Now what happens is all these other folks, the few who actually have insurance in these rural towns, right? They're cut out of the picture if they don't have that. And then folks who don't have insurance, they're no longer, there's no like cash pay or kind of, different systems. Like my parents, for example, I mean, man, like I mean, most people during that time did not have health insurance, right? So they'd bring chickens or whatever they'd bring, and
Right.
they made it work. But the problem is, in similar fashion, I don't know if you kind of keep tabs on this stuff. Recently in the real estate market, what is happening is, not to segue, but lots of folks can't buy homes that are affordable because private equity is coming in and they're just private industry. They're just coming down. JP Morgan, here you go, cash payment. We don't need you to inspect the house. We don't need to do anything. Here's $350,000. Thank you. And now, right, those individual home buyers don't have access because this large mega corporation's coming in and buying everything from out under them, right? So President Trump is, he's trying to stop this. And in a similar fashion, though, this is what's happening in rural places. Private equity is coming in and buying up these hospitals, these independent physicians at very high rates. And they're making the claim that, hey, we're helping people, we're making care more advanced, and we're whatever we're doing, but that's not the case.
And it's getting worse, the access issue.
Yes, in my experience.
Okay, so it sounds like you would want to see a similar type prohibition to private equity buying physicians' practices in rural America, just like Trump is stepping in on the housing issue.
I do. I think it's a really big problem, and I think that large health systems and private equity, we need to stop this. But then I will just say that this is ultimately, I don't want to say the fault, but this is the manifestation of Obamacare. Of 20 years out or whatever it is, right? 2 decades out, that a lot of these independent providers are struggling because they can't do the electronic medical records. They can't do, some of the huge regulatory things that the government's putting on them. And so they're struggling to survive. And then the big shark comes and eats them. And then in the end, the real people who suffer are these patients.
Okay, so you hit on a frequent topic of conversations we have here, and a lot of time that I've devoted in public policy and reform of the Affordable Care Act and its many shortcomings. Let's go back to maybe a root cause here, if you're prepared to. I don't want to put you on the spot, but it sounds like private equity moving in and buying these practices, that is sort of a consequence of the underlying dysfunction of the rural health market. So let's suppose Trump was going to say, I'm not going to ban private equity buying medical practices. What else would you do to change the underlying structure in order to get more physicians in rural America, more nurses in rural America, and more patients seen there?
Well, I think, for example, these independent medical clinics in rural areas, I think that they should be paid much more at a higher rate for the government to incentivize folks to come out. Because look, as because you've been in this game for a long, long time, right? You want to follow policy, follow the money. That's you pay for what matters. And in rural America, we're not doing that. And I just think that if we financially incentivized primary care doctors, others to go to smaller towns, you would see more people there than you knew what to do with, because it would be financially in their interest. And I think if we had a more aggressive loan forgiveness program, or we really made it in the financial interest of physicians or nurse practitioners to go do these things, I think it could be a lot better. But I mean, I'm just telling you as putting on my orthopedic trauma hat. I mean, right. I've seen people who lost their legs because they literally could not find like an ER or a place that was close enough. And when it was too late, this to me is a huge challenge.
Right. Now, one thing, there were, post-World War II, we had some great loan programs for doctors to do exactly this. we wanted more doctors. We said, okay, there's a need. Doctors are a good thing. So we're going to invest. There were a lot of loan forgiveness programs that have been scaled back over the years. Are you proposing, a reinvigoration of that? I mean, sometimes you can graduate medical. I don't know if your parents paid for you, but what the bill was for you by the time you got done with college, medical school, residency, all that stuff. I mean, that's not a small amount of change. And it must have been, it's awfully tempting for a lot of people in your situation, and sometimes an imperative, let's be honest, if they're able to go to school in Boston and practice for a little while up there, to never leave because they got to pay off their loans, right?
Yeah, that's right. That's right. I just believe that government creates more problems than they solve in general. Like that's my heart.
Mm-hmm.
But I do believe that, the government of the United States is the single largest healthcare payer, right? So they have a lot of power in terms of guiding and directing, what happens in American medicine. And so, I think you create separate DRGs for rural episodes of care, pay them more. I mean, student loan forgiveness programs that are more aggressive for those folks who choose to go to rural America and serve, for, a decade or more. Sure. But I just believe, again, follow the policy is following the money. You make more as a plastic surgeon in Miami than you do in being a primary care doctor in Hillsborough, Tennessee. And that's why you don't really see a lot of primary care doctors in Hillsborough, Tennessee, just a fact.
So when you guys are done, say you screen somebody and look at somebody at the Healthy Tennessee event, what happens to them when they're done? Like, where do they go? And then do you follow up with them as Healthy Tennessee? Or are you like, man, we're not doing another event here for 3 years because we got them all over the state? How do you link them to care once you're done with one of these visits?
So it really depends on the patient and what happens. So let's say we saw this patient that I had mentioned earlier with potential breast cancer that we saw on Saturday, right? So we connected her with the Rutherford County Health Department on Wednesday, I think it was. We reached out to them to make sure that there was a connection, that the patient had called them, and they did. And so we moved on. Let's say you have a patient with a blood pressure of, 200 over 100 or something like that. I tell them, look, you need to go to, and they don't have a doctor. You need to go. We partner with a lot of urgent cares. So we have friends across the state, different counties, urgent cares with private physicians who will see our patients, get them in. I will follow up on those things. Let's say you're somebody and you have a basic problem that is not really highly concerning. Then we will give you a couple of numbers to different urgent care places or county health departments. And the county health departments have been incredibly helpful to us, or community-based health clinics. So if you don't have like a major problem, honestly, we'll point you in the right direction and give you some contacts of like people who are friendly to us. If you have something more serious, we follow up and make sure that there was at least a point of care contact made.
Some of these people don't have any insurance. So do you have a network of people that will see uninsured patients as well as part of their charity care, or what do you do in that circumstance?
Exactly. It's almost like I owe people many favors because of all of the things that they've done for me over the years with these patients, like hundreds and hundreds of favors, So yeah, we have tons of healthcare providers across the state that we've just gotten to know over a decade and a half, and they just kind of help us.
Let's talk a little bit about your hospital experience too, while we got you. Mm-hmm. So that's a pretty intense practice for you to be seeing people with massive trauma and broken bones. And the first place you see them is the emergency room. It's got to be pretty stressful. What happens to those patients in the emergency room and then they're staying upon discharge? I mean, where do you see that as part of your practice? We talked about rural health, but you've got this other really intense practice. Some of those people have got to be uninsured, underinsured. Some of them have got to be Most of them.
Most of them. I mean, look, the work we do is it's pretty crazy, man. I mean, like this week I was on call. A van hit a Coca-Cola truck head on. 17-year-old girl and her father. The father died. We saved the 17-year-old girl's life through multiple surgeries, my partners and I. And it's very hard. I took care of a lady about 4 weeks ago who came in, looked fine, complained of some, leg pain, and about 30 minutes almost died because she had this flesh-eating bacteria.
Ugh.
So, the work we do is, we're the third busiest level 1 trauma center in America.
Really? Why is that? I wouldn't have thought that, right?
Oh,
I mean,
yeah.
you've got LA. I mean, I would think Miami, LA, Boston, New York, the second one and the third one in New York. Why are you guys the third?
Because we have this interstate system where you can drive really fast and, 70 miles, 65 an hour. And so there's a lot of, and think about it in New York and Boston and all these bigger cities, right? Traffic moves pretty slow. But when you're in rural Tennessee or wherever you're at, or Indiana, or, Southern Illinois or parts of Kentucky, right? You can, so when you're on a motorcycle or, whatever.
Okay, so we're running out of time, but I'm finishing up with preventive care for a second, because you see a lot of people, for lack of a better term, in extremis, in desperate need of care. Any wishes or hopes you would have about preventive care to avoid either seeing them in the emergency room as part of your principal practice, or showing up at a Healthy Tennessee event with something grievously wrong?
Absolutely. We're just doing it all backwards, man. We're taking care of sickness on the back end rather than getting on the front end of the problem. And the reason is because in the United States of America, brother, we pay for sickness. We don't pay for wellness. And
Right.
so I think that we need to really gain the trust of the American people. And that is, done in a individual to individual, patient to doctor, when they trust you. And that comes again from kind of what we talked about earlier about knowing their story, knowing who they are. And when they trust you and you can educate, people listen. And that's what I found at these Healthy Tennessee events, is that if you really take the time to talk to someone about their lifestyle and eating a little better, maybe walking 30 minutes a day, and how it could change their blood pressure or change their, picture, I think you could do a lot, but we're just not doing that enough. And our system is not built like that, because these pharmaceutical industries, all these big hospital places don't make money if we do that. And that's what we have to change that.
Well, there's two views too, I think, that compound the problem. One is internists or family physicians are not as valuable.
That's right.
And that relationship is not valuable, even more so. That's, I'd say, one thing, like the relationship that a family physician or an internist would have, sometimes generationally, with a family, is not as important as, say, technology or EHRs or DRG codes or whatever. That's one. The other one is these people are hopeless. People in a certain socioeconomic group, whether in an urban or a rural area, in some cases there's a racial component to that. People saying this group is hopeless, and they just, it's not worth it. It's not worth the investment that Dr. Manny is putting in. There's not a good ROI. These people are so dysfunctional that it's obvious they shouldn't smoke. It's obvious they should walk 30 minutes a day, but they're not. And we don't have the resources to invest in Dr. Manny's relationship and conversations with them.
And I hear and I agree with everything you're saying. But here's the thing. I think everybody's got this light bulb, right? And for them to change behavior, you got to flip the light bulb on, right? So the question is how do you do that? Like what, and that takes time, and that takes a lot of effort to get to know somebody. And so I agree, but I really deeply believe that no matter what person of, like, wherever they're from, whatever their socioeconomic background, you gotta reach them, man.
Right.
And I'll give you, like, I've got patients, man. I got people who are meth addicts and coke addicts, and they're smoking, and smoking prevents like fracture healing. So they, break their femur, and their femur's not healing because they're smoking. And like over time, I'm telling you, I've reached a lot of people about with smoking cessation who have the craziest other problems, because I'm like, look, you're not going to heal. You're not going to walk. Like, every time you smoke a cigarette, say to yourself two things. One, I don't want to walk. And two, I'm going to lose my leg over a cigarette. And it, like, literally, it reaches them. And so I'm not saying everybody, I'm not saying all of them, but I believe in people. I really do.
So this is my last question before we wrap up, but you alluded to faith. That's got to keep you going on some of these days, right? I mean, you must think, if I didn't believe in God or wasn't religious, it would be very easy for me to quit.
Oh yeah. Tuesday was a very hard day. I mean, you just walk out of there and you're like, at some point, this 17-year-old girl in the next 12 hours is going to learn their father's dead. But yeah, man, I just think God calls you to do different things. And in my case, I think God made me to help others. That's where I gain my satisfaction. And I said the book of Matthew earlier, Matthew 9, the harvest is plenty, but the workers are few. So it's like we, all this work to do, and but we just don't have enough workers. And I derive my life's meaning by making a difference. Like, man, we did this health fair on Saturday. I went to bed feeling so good. I was like, look, we helped some people today, and that's what it's about.
Well, thank you, Dr. Manny, for joining DCEKG, but more importantly, thank you for the work that you do. It's inspiring. I'm sure you're helping a lot of people out there.
I really appreciate it. And if I can ever be of service, just holler at me.
Thank you.
All right, brother.
I want to thank Dr. Manny Sethi for being our guest and sharing his insights. If you want to learn more about his work at Vanderbilt and Healthy Tennessee, we'll have links available on the DCEKG website. This episode was sponsored by Survivors for Solutions and produced by Stay On Course Studios with executive producer John CZ Swartacki.